Thank you very much and good morning. When the loss I was involved in was mentioned, one of the laws that we actually fought for, I fought for that initially on my second term. I was with then my deputy, who's now the mayor of Makati, Abi Binay, and not much attention was given to it, even up to its passage. Nobody realized the importance of that. That's actually the amendment of the PhilHealth law. And this is something that we should again look into because it's not just the mere passage of the sin taxes. It's not just the Reproductive Health Care Act. It's not just government moving forward. It's government, private sector, health financing, all working together because health for Juan and Juana wouldn't wait. And last year's forum was indeed a success as it became a venue for stakeholders to understand the current state of the health system and gain a consensus on the next administration's health agenda. Almost always the question on health is continuity. Because sometimes if you have a program and then there would be a change in leadership, just like in any private corporation or private organization, and even in an NGO, with a change should be proper turnover so that whatever has been started will be continued. But will it stop there? No. The forum last year made possible the gathering of inputs from experts, not only on the side of government, but the private sector as well, because that is important. When we talk about health, medicines, hospitalization, healthcare financing is inevitable, and government can stay in its closet. Private sector cannot stay on the opposite side. Juan and Juana, the Health for Juan and Juana Forum brought a platform wherein these two big bodies can unite for the common good, because at the end, its ultimate objective is to deliver for Juan and Juana. And we were privileged during that time because we had Secretary Cabral, we had Secretary Duque, Secretary Dairit, and Secretary Ona. Moving forward with the Philippine Health Agenda, last year's forum, the imperatives has been summarized as follows. Let me go over it one by one. Reducing health inequities. Of course, disparities in health outcomes is very obvious. There is a socioeconomic group and geographical areas, which is usually aggravated by misinformation. And pardon me for this, I hope I'm not trampling on anybody's foot, but there are occasions where entrepreneurs would take advantage of the lack of knowledge of some of the major stakeholders of health. And that is, like for instance, we have a lot of cancer patients who would prioritize expenditures on herbal concoctions, on newly found medicines which are not actually bound by science. And this actually depletes them of the money that could have paid whatever social health insurance can contribute. And in terms of geographical areas, the farther you are from the bigger cities, the more vulnerable you are to wrong information. What with social media? I remember when somebody posted a call for panic when Zika virus was diagnosed in Brazil. And every mother who would look at their baby would stand in fear and say, oh, my baby's head is small. But actually, the baby is also small. So we had to go out and say that it's the proportion of the baby's body. Microcephaly is not just a small head. It's a small head as compared to the body. But mind you, because of what came out in social media, each mother who was about to deliver was concentrating on diagnosing, on thinking whether the child has Zika or not, instead of thinking of what to prepare and where to go at the time of delivery. Poor access to health services. Services do not reach those who need them. This might be due to geographic, information, or even financial constraints, but even the peace process is a very important barrier when it comes to health delivery. Reducing the out-of-pocket expenditure. This is a very, can I say, abused term, because it's true, the out-of-pocket expenditure is so high. It was placed at more than 50%, but as we were looking into the real figures, it was more than 65%. On the average, 65%. And why? It's simply because we also, in the medical practitioner side, are guilty of one medication to another medication, the conflict of interpretations, the conflicts that science has created, because we as human beings would usually have dissenting opinions. But it is worth for this dissenting opinion to go down and affect the finances of our patients. And it should be no. Sometimes, in our desire to give the cheapest to our patients, we give them and we look for the cheapest, either the cheapest equipment, the cheapest medicine, the cheapest area, but sometimes cheap does not usually transcend to quality. And always prioritizing what's the cheapest without considering the impact and the quality of what you are giving, the quality of health service that you are giving, would actually tantamount to a higher out-of-pocket expenditure. Why? Because at the end, they still have to go back and look for what quality health service can give them. Unnecessary health expenditures, as I have mentioned earlier, and the fact that there is no accountability. It was discussed, and Secretary Cabral is very active on this, that while we do appreciate and respect the opinion of those who would push for herbal medications, except for some, but there are others that would actually, instead of helping, pulling down the resources of a family, especially if that family or that patient has a catastrophic disease. And others were saying in that forum, they said, but it's a choice. You can always say and they can choose. But in the culture of a Filipino, I believe in other Asian countries as well, if there is a member of a family who is inflicted with a catastrophic disease, almost always the initial reaction will be, we'll spend every peso left in our family just to let that patient live. And this is, again, a huge factor in terms of contribution and out-of-pocket expenditure. So if you want to reduce out-of-pocket expenditure, it's not merely the government, it's not only the private sector. Most importantly, there should be awareness, proper information, and education among our families. PhilHealth has been very active in somehow reducing the out-of-pocket expenditure. But are the efforts transcending to the people? I worked with Dr. Mingita Padilla, and as we were analyzing the figures, we were definite that while PhilHealth kept on moving for the betterment in terms of reduction of out-of-pocket of expenditures, sometimes there are hospitals that when you increase the coverage, they would also increase the cost. Let's say for medicines, if you say medicines are expensive, it's because they become more expensive when you charge it to PhilHealth. And when this happens, when you talk about reducing out-of-pocket expenditure, it should not be left on the listen and engage portion. It should be on the call to action. And that responsibility lies in each and every one of us. And this diagram illustrates a complex patient journey through the health system with emphasis on the possible drivers of out-of-pocket expenditure. The no balance billing has a good intention. It's a good program. But during last year's forum, while it's a good program, there was also the apprehension of the local government hospitals and the smaller hospitals bleeding rather than sustaining itself. The out-of-pocket expenditures tends to increase in private facilities, but patients still go there. Others say because the private hospitals are more than equipped than the government hospitals. Pardon me, but I beg to disagree. I just saw Dr. Bong Vega when I went to the hospital that he has partnered with the Department of Health. You can't feel that you're in a government hospital. It's not about the physical appearance. It's not about what service can the private sector provide, because government is richer than the private sector. And the equipments and the mechanisms that are available and that can be available in the government hospitals are a lot better. But the huge difference is the TLC that goes with it. In the private sector, the human resource are geared and taught on how to move forward, on how to cater to patients, on how to tap them, on how to smile and assist them, on how to make them feel that they are welcome in the hospital. And these were the problems that these were the feedback that we were getting during that forum, that it's not just an infrastructure, it's not just providing a doctor, a nurse, or even the medicines there. It's also creating a way of communicating, that when a patient goes to the hospital, they would know where to go, how to go, and who will assist them. And mind you, one of the things that we have discovered is that how fearful it is for a patient to fill up the PhilHealth form, where you have to put in the names of your children and recall the birthday and the birth year of your children, because some mothers forgot. And that alone threatens them. And so that was why PhilHealth, before we left the government, went on a database program wherein you don't need to fill up all this family. It was called the MD form. It's a social form. I've somehow went over some of the proposed courses of action: increasing funding for health, raising PhilHealth premiums, and exploring tax-based sources of funding. While it is true that we still need more funds for health, during that forum, not only during that forum, in several forums prior to that, and as a former Secretary of Health, I was privileged to sit in the PhilHealth as the chairman of the board. We realized that there were a lot of duplications. Medicines that were being paid for by PhilHealth was also being provided by the Department of Health. So the delineation between public health and health financing is something that should be clearly defined. Well, it's clearly defined in the global and the national perspective, but inculcating it in the minds of our government officials and other stakeholders, of the major players in the Department of Health and PhilHealth, should be very vital. The board should be thinking of what programs to give that will reduce the out-of-pocket expenditure, because that's self-financing. On the other hand, those programs in relation to public health, like maintenance medication, preventive health care, should be given to the Department of Health. Why? Because avoiding duplication of expenditures will actually create a huge impact in terms of reducing out-of-pocket expenditure. Exploring tax-based sources of funding was also one of the proposals, and everybody agreed to that. However, it should not stop on tax-based fund sourcing. Aside from taxes, it should be coupled, and they should go together. They should be like a couple. Proper planning should be in place. We cannot move forward with 2 feet and then put the left foot for more taxation, and the right foot is moving backwards in terms of planning. Because when the sin taxes was approved and we were making a review of what happened, we realized that much focus was being given to the approval of the sin taxes, but nobody was planning on where it should go, how it should be done, what's the long-term plan, the medium-term plan, and the short-term plan, and why it should be in place. It should not be changed with every meeting. Integrating sources of health financing, we also have PCSO, we have PAGCOR, and they are the huge players in terms of reducing the expenses of catastrophic diseases. But mind you, there is no single platform that would actually combine all of this all together so that priority is given to those who really needs it. The diseases and the situation of patients whose expenses can actually pull down a family in terms of financial resources. Just like we have cancer, we have renal patients, we have patients who would have cardiac problems and will be in and out of the hospital. We have patients who would go into complications of infectious diseases. These are situations where a middle-income family becomes poorer, and poorer. And that alone is a poor reflection of we don't invest on health. And if we don't plan well, and if the new administration will not be able to reduce more the out-of-pocket expenditure, then it will be very difficult for us to take off, because health and economy goes hand in hand. There was also, and we have this proposal several times, building PhilHealth as a strategic purchaser. However, during the time, with a year in office, the documentary requirements needed was not enough with that span of time. So this was one of the major proposals that PhilHealth should not be used as a political package. It should instead be used as a major purchaser of certain drugs, certain medicines, and certain procedures, because pulling down the cost will actually affect the whole market, and I believe industry here would agree to that. However, again, there was always the conflict of people saying, no, PhilHealth cannot procure because it's against the internal laws. That's why you have a board, because that can be amended. And this was one of the biggest proposal that we turned over to the next administration. Because if PhilHealth can build up and instead facilitate, especially for smaller hospitals, even the private sector, who would be needing innovative medicines, then that would be very beneficial. And then there was always the question of the existence of the Formulary Executive Council. Because if the private sector will not be allowed to procure medicines needed by most of the patients, you cannot dictate on how a doctor manages a patient. You can influence, but you can never dictate, because the sole responsibility lies on that patient. Again, the other courses of actions, and let me move further because I'm very conscious of the time just on my right. Improving access to quality medicines and health services. There is ensuring adequate financing for enhancing service capacity. There was also the issue of vaccine stockouts. Why is it that in other countries they can plan ahead? Why is it that in our country we plan as the year comes? And sometimes if the plan is already there, we have to change it. The impact on pricing is very huge. The issue of professional fees has also been tackled because there is no body that allows, and this is one of the legislative proposals that should be made in place, an integrated organization that would look into the medical profession. And the referral system. A performance-based allocation of resources was also proposed. Why? Because most of the hospitals, the performing hospitals, would sometimes get the smaller share. And the non-performing hospitals would get the bigger share because they will always fight for a better subsidy. But is this really where we have to move forward? Or will it be the other way around? The EU and I think USAID has helped us with the yardsticks for a performance scorecard in terms of government hospital allocation that needs to be improved and widely implemented. Addressing the gaps in human resources for health. We did look at the rapid turnover of human resources, and that is why we have the universal healthcare implementers, the public health assistants, but these are actually the non-licensed doctors and the non-licensed doctors who would like and who would opt to stay there for where they carry the institutional knowledge of what happens before and what happens after. There was also the issue of the human resource in terms of maintenance and of technicians in hospitals is something that the Philippines should look into. A partnership with some of the European nations was put forward, but of course this still has to be formalized. From MDGs to SDGs, there is the issue of a no-contact policy that would sometimes deter the platform of innovation, innovative medicines, being able to tap government resources, especially when we talk about government subsidizing expensive medicines. And so if we talk about MDGs to SDGs, as it moves forward, as our goals move forward, there is also the need for a platform to come together and talk together, because almost always the barrier starts with the government thinking of the possible cases that he or she will have in case he or she opens her doors to the private sector. Let me borrow this slide from Secretary Cabral. These are the unfinished, the new, and the pervasive agenda that we need to address as we transition from the MDGs to the NDGs. Indeed, much remains to be done, and it will never stop. Even with us leaving the public health sector as we retire in the future years, it will never stop because innovations also would never stop and the discovery of diseases will never stop. But what is important is that we have a platform wherein decisions, lessons learned, and future actions can be collated so that all of us will have a collective, symbiotic direction for the better good and delivering for Juan and Juana. Thank you very much. I actually place #Help for Juan Juana. It's a never-ending number because your service and your commitment should not end even in the future generations.
Thank you once again, Dr. Garin.